I want to introduce myself. For those that may not know me, my name is Kathleen Vollman. I'm a critical care clinical nurse specialist. And I was just sharing with a colleague, we started nursing at the same time. I've been a nurse for 44 years, 10 directly at the bedside, 13 at the bedside as a clinical nurse specialist for the medical ICUs at Henry Ford Hospital in Detroit, Michigan. And for the last it's now 21 years this August, I've had my own company called Advancing Nursing, which is focused on creating empowered work environments for nurses through knowledge, skill, and process. So that's what this goal is about. Also, this year, I became the president of the World Federation of Critical Care Nurses. Just a little something added on to my journey. But thank you for joining me on a talk that is near and dear to my heart, is how we can really reduce the amount of microorganisms existing in our environment that are impacting our patients on a daily basis. And what role can we have and play in reducing and creating that source control in our environment? I am a subject matter expert for the American Hospital Association on CAUTI and CLABSI reduction, as well as pressure injury and sepsis, early recognition and management. And in the past, I've been sponsored by these companies. But it's important to know, no matter what talk I give, it's based on the evidence, so it doesn't matter if it's sponsored or not, the science is the same. So, objectives, because we're teaching and learning, right? So let's talk about transmission modes in our environment. Needless to say, we're going to talk about these puppies. I like to call them lethal weapons. And I'm very excited that the CDC is moving the stethoscope to a lethal weapon, to a high transmission device. It's about time. Sorry, a little commentary thrown in there. Analyzing evidence-based key practices, that's where we're going to spend the bulk of our time of what we can do in our clinical environments to reduce that load. So I want you to leave here with one or two practices that you feel you can take back if you're not already doing it, or improve that practice to reach the level it needs to be able to reduce that bacterial contamination in our environments. Guys, this is a big issue. CDC estimates on the MDROs, we're looking at close to 1 million a year infected with this. And you're talking about almost $5 billion in healthcare costs associated with this. And that doesn't include the pain and the suffering that our patients go through as a part of this process. So, pandemic levels, the infections went, whoop, and we all know why. I mean, access, we didn't do the same practices that we routinely did. How many have started to have to rebuild all their quality programs in their environment? Yep, don't worry, you're not alone. See, you saw all the individuals that raised their hand. It is an around the world issue of having to reset our cultures to get us back to where we were. And I will tell you, the most recent report that came out of Leapfrog is our infections are down, because of the work you're doing on a day-to-day basis to re-engage everybody in the journey as a part of it. Any given day, 31 hospitalized patients will develop an HAI. That's big, and a good portion of them are preventable. Everything, no, but a good portion of them are. I truly believe it is mostly an avoidable adverse event. I think there are absolute things that we can do to reduce the risk our patients experience with this. There is a mortality rate associated with this, pretty much a jetliner crashing every day. And if you think about it, do you see this on the news? Not as much as it should be, as a prominent issue in our clinical environments. It leads to increased length of stay, increased morbidity, and increased mortality. All of the things we don't want to have happen in our environments. So, do any of your patients fit this risk factor? Prolonged hospital or ICU length of stay, yeah. They had a surgery or procedure, yeah. They've got a device, yes. And are they on antibiotics? Okay, so you can tell the majority of the patients we care for are at risk for the development of a multi-drug resistant organism infection. So meet the hospital staff. Sorry. Got to have some fun. And boy, did I have to go after some copyright-related things to make sure I got to be able to use this slide. So what are the common routes of transmission? These puppies, they're lethal weapons, and now the stethoscope hangs right with it. The other is the environment, and then the patient themselves. So those are the three big vectors of infection and transmission that I want to focus on in the time I have with you. And when we look at data, even though this is a bit old, we do know, based on studies that have happened since this, patients' endogenous flora contributes 40%. Anybody bathing different than they did 10, 15 years ago in the ICU? Science is related to that. Cross-infection by these puppies happens about 20 to 30%. Antibiotic-driven changes in flora. How many of your organizations have a stewardship program? Pretty much everybody, exactly. And then the environment. So, and they all interface with each other as a part of that journey. How many have heard of the concept, and you may have heard of it from your infection preventionist, this concept of either vertical management of MDROs or horizontal management? Vertical is an older way of looking at it. We still do that probably for the emerging bugs, but for the ones that have been hanging around for a while, MRSA and VRE, there is a more horizontal approach. Vertical means I take a single bug, I swab you, I plate you, I isolate you, and I do good hand hygiene. The horizontal approach is the entire joint has got microorganisms everywhere. So we're gonna bathe them a certain way. We're gonna not really isolate them, only for very particular things. No screening. We're going to do CHG bathing, and we'll delve more into that science. Limited lines and tubes, and then good hand hygiene across the board. So that's the difference between the two, and we've been moving heavily towards the horizontal practice, and nasal decolonization is another component of that journey. So when do we do active surveillance? A lot of times you'll see it prior to surgery. They want to make sure that nothing is already present, they're not a carrier, so that they increase their risk for infection if we don't address it straight off. When else? When we have a high-risk population or an outbreak, that's when you'll see screening. Is anybody doing routine screening on entrance to the intensive care unit for MRSA and VRE? So you guys still are. There's not a whole lot of data to support that anymore, just to let you know. So that's one of those activities that could probably drop off and you'd be okay, unless you're in a place where you've got breakout or a significant high-risk population. And then CRE, high-risk population based on if you've got a large group coming from LTACs, or you have a lot of foreign travelers, things like that put that group at risk for CRE. And so you want to know about that. So how do we go about doing this? Well, hand hygiene and stethoscope hygiene is one bucket. Decontamination of the environment is another bucket. Patient decolonization is the third major bucket. And then the minor, I don't call them minor buckets, but they only gave me an hour, so I couldn't do everything. When do we use contact precautions and isolation? Another is our device-related bundles, our CAUTI bundle, our CLAPSI bundle, our VAP, non-vent pneumonia bundles. And the last one is ensuring that you have an antibiotic stewardship program as a comprehensive plan to really reduce the bug levels in your environment. So let's start off with hand hygiene. For those in the back that may not see this, it says, I use so much alcohol-based hand sanitizers, my hand had to join a 12-step program. Now, anybody, I'm going to say this too many times, anybody old enough to remember when this stuff ripped up your hands before they actually put the lotion in it continuously, so it made it much easier as a part of that journey? So I have a question to ask you. I'm using old-fashioned polling. What is the average number of times a clinician should be cleaning their hands in a shift, and that's a 12-hour shift? Is it A, 35, B, 50, C, 75, D, 100? It's D, 100 times. Guess what the data shows? Less than 50% of the time do we achieve this. So we always have an area of focus that we need to improve. And I gotta tell you, one of the things you can do is go back into your environment and see if you have hand hygiene dispensers on the way into a room and on the way out. I'm not talking about further into the room, but on the way out and way in, so that you at least have absolute in and out, and then somewhere close to where the bed is to be able to change and do hand hygiene with procedures and things like that. It is the most efficient measure that we can do, and we still don't achieve 100% on this. So it is an area we can improve. So what is the number one type of hand hygiene we should be doing in our clinical area? I forgot to tell you I'm an interactive speaker, so I'm going to engage you this whole time. Alcohol-based hand hygiene. The reason why it came about is because you can kill it in 20 seconds versus the 40 to 60 seconds that the washing the hands. Nobody ever sang happy birthday long enough when they're washing their... Do you ever walk into the bathroom, happy birthday to you? As a way to remember how long I should be washing. So we do the hand hygiene when our hands are visibly soiled. Most of the manufacturers will tell you 15 to 20 times of an alcohol, you should be doing a hand hygiene. And then if you're dealing with spores, but I gotta tell you, the data with soap, soap, antibacterial soap, and hand hygiene for spores, it's no better than the alcohol. But right now, the CDC recommends that visibly soiled hands or C. diff spores, you use hand hygiene. No triclosan, decontaminate before and after gloves. We have a belief that gloves are this magical thing. And we don't pay attention to when we take them off, making sure that we do hand hygiene in between things. Lotions. Any of you carry lotion in your pocket? If you do, that's a bug fest. You need to have that go bye-bye. It's a liquid, and you're repetitively opening and closing it. If you have the big bottle of lotion at your station, get rid of it. It's an open source of bugs going in, having fun in that wet environment, and then you're putting it on your hands and rock and rolling. The best thing is hospital dispensed lotion in dispensers that are in contained environments that are refilled. That's the best strategy in managing that. How many had to take their nails off? You want to take your nails off. You do not want to be wearing any of that kind of stuff. And if I was still frontline, I wouldn't be wearing my rings either, because there is just too much collection in that environment as a part of it. So, the efficacy of which we do hand hygiene, if we miss parts, if we're successful at doing it correctly, we can go from a 60% kill to a 90% kill. So by the way, the WHO has these wonderful infographics that you can put up right on top of your hand hygiene and right on top of your sink for efficacy of helping people remember what you should be doing. The scrubbing of the nail piece in the palm gets missed a lot. And actually, there's a wonderful tool right here that shows sometimes missed and frequently missed areas. So it's a good educational tool, because you can't do the fake bug hand hygiene thing. That usually gets done once a year. This allows you to remember where the potential areas of miss are in this journey. We do know that even with fairly decent hand hygiene, what we consider as a regular practice, they still are on our hands 9-10% of the time. And that means cross-contamination and transmission to other patients. So, at a minimum, guys, wash in and wash out, at a minimum. And then if your hands get engaged in any patient procedure, that's the other time it should happen. So those are your there's 5 moments of care. But I got to tell you, if you measure in and out, it is similar to capturing the 5 moments in terms of total efficacy of hand hygiene and reduced transmission. So I go for that. So what's the best way to evaluate this? How many of you know when the secret shopper is around? So they're not very secret. I was at a place that actually has cameras everywhere, and the IP is in a side room watching and doing the secret shopper that way. You guys got it like that? Yep. Another is product measurement. There are multiple studies that show, depending on the amount of product utilization, you can estimate the percentage of compliance with hand hygiene, because we know how many episodes should be occurring. So we know how much should be dissipated out of those dispensers through the process. And then any of your organizations have electronic assessment. It is very effective, but it's only effective if it doesn't feel like Big Brother watching, but that it's collectively used as a group, as a unit to say, here's where we are in this journey, and this is what we need to work on from a quality improvement perspective to get to a better spot. It shoots out a lot of data, but you gotta be very mindful of using that data. Otherwise, it's just too much data and nobody's doing anything with it. So those are some strategies. And like I said, here's a study showing the amount of alcohol rub in comparison to compliance with hygiene. Did anybody know there's 5.5 billion episodes of stethoscopes on the chest in a year? That's a lot to not even be thinking about it. Do you know what the previous CDC recommendation was? Once a week. Shoot me, once a week. So the pathogen, the volume diversity has been identified to be identical. 85% of the same pathogens that are on your hands are on that stethoscope diaphragm. So it's clear. Patient contact, boom, where does it go? Right to the chest. How close is that to all of this? Into the central line, and to all the other things that there. So it is a transmission vector, and often referred to as the third hand, you know, if you want to think about it and put it in that context. However, there's a couple dirty secrets. No pun intended. Stethoscopes are nasty, and they're covered in bugs from the last patient, and nobody cleans them. So this was data on route of transmission, where they looked at a 3-month observational study on known MRSA-infected patients. Patient contact, they looked at gloves, hands, stethoscope, diaphragm, and clothing touching the patient. 52% on the gloved hand. That's why you got to take the gloves off and clean your hand afterwards. Clothing, 48%, and your diaphragm of your stethoscope was at 40% contamination. In direct observation of cleaning stethoscopes, only 4% occurred. So do you guys, how many of you now use caps on your IV ports? It's pretty much widely adopted. Same technological focus. Nobody scrubbed the hub for 15 seconds. It just never happened. So we looked at technology to try and help us address that concept. And that's really where the science is going. If you clean your stethoscope with alcohol, is that sufficient enough to remove C. diff and other pathogens? And the answer is no. The science shows that this stuff sticks around. It'll eliminate some of it, but not all of it. Probably about 30% of major MDROs still on there, even after cleaning with alcohol. I know. So, how many enjoy using the isolation stethoscope disposal? Nasty. Absolutely nasty. And by the way, it also has significant diagnostic inaccuracy. You try and pick up a murmur on that puppy? Not going to happen. And so literally, technology, where you wave it over, slaps a cover on it, you put it on the chest, you take the cover off, and you walk out the room. Very much like putting the alcohol cap on the IV. Similar concept. So again, I believe technology is going to help us overcome that particular barrier as a part of it. So always remember, my child, only dead fish go with the flow. So basically my message is we've got to change our practice around stethoscope hygiene and the hands. What about the environment? Got to tell you, substantial scientific evidence showing the environment as a major culprit for microorganism spread in our clinical. So, what is the problem? Does anybody want to be a patient in the room of a patient that had an MDRO? Now, I will tell you, these are slightly older studies. Now that we have ultraviolet C and some of those other strategies, I'm leaning a little more towards I could be okay with it. But prior to that technology with just terminal cleaning, you're looking at a 5 to 6 fold increase by just entering a room of somebody that had a multi-drug resistant organism infection. I know, it's pretty scary when you think about it. And by the way, does anybody believe the curtains help with anything? Yeah, that's right. As a part of that. So what are the recommendations? The recommendations really exist from environmental services to have a very, very structured process on how they clean rooms. How many of your environmental service people have stopped touching the monitor and cleaning the monitor? I'm sorry, it's part of the room. It's part of a clean. It needs to be included in it as a part of it. And we need to partner with our environmental souls to get them to understand how important their role is in preventing harm to patients as a part of this journey. So it's important to reinforce and ensure that they're doing effective cleaning techniques. How many have implemented daily disinfection 2 times a day on high-touch surfaces? Yeah. Now, when this first came out, I'm thinking, another job that's being put on a nurse. And then I talked with nurses all over the country, and they said, you know, it's one of those times where I actually can go in the room, I'm not hanging a med, and I can clean and talk to the family or talk to the patient because I don't have other high-risk activities going on. I went, oh, okay. But it does work in reducing the burden in the environment. However, we need to keep those surfaces wet for 1 to 2 minutes, and that often doesn't happen. We want to dry it so it looks all pretty, right, after we clean it. So even when there is significant work on improving terminal cleaning, so this was 27 acute care hospitals where they used the fake bug process, and they would go in and they'd terminally clean, and then they'd bring in the black light, and so they would improve. They'd do that over and over again. They did it about 5 times. They went from a 50% effectiveness to an 82%. That's as high as they could get. So what that tells me is we need something more than just the terminal clean in the environment. And that really goes to the science of no-touch cleaning. How many of you have implemented the science of no-touch cleaning? So this is, it's been shown to reduce the rate of infection. It's ultraviolet C, hydrogen peroxide bombs, basically, I like to call them. Most of us have not adopted the hydrogen peroxide because that takes roughly 2 hours. Who's got 2 hours to turn over a bed? Not too many, not too many ICUs, I know. So it's very effective, but most of us have moved to ultraviolet C. How many of you shove every piece of equipment in that room that's going to get zapped with the ultraviolet C so that you can get everything clean as a part of it? Yes, that is true. When you look at it, it's 10 to 45 minutes for C. diff. And by the way, you got to make sure something's targeting that toilet. The bathroom. Can't forget about the bathroom especially in the C. diff world. You can't forget about the bathroom as a part of that. And it's about 10 to 25 minutes for the other MDROs. So literally, at the most, we're talking 45 minutes. I can do that to prevent harm to another patient coming into a room. I can make that happen as a part of it. What are some additional factors? Hospital curtains. There's some technology where they've embedded some microbial fabric material that allows the hospital curtain to last 7 times longer. Because any of your environmental people good at changing the curtain every time? You got a good one? You have to call. That shouldn't be on a nurse's plate to have to call. That should be just part of what is routinely done, but it's not necessarily the case. We talked about the cleaning of high-touch surfaces. One of the things they're looking at from another technological is infusing of copper into bed rails, into side tables, as a way to reduce, and silver as well, to reduce it. It's not the cheapest material. They're also looking at the counters and the sinks as a part of that journey as well. So interesting things to try and help reduce this overall burden. Now, how many of you went to disposable EKG leads because you believed that it was going to really reduce infection? Science says it's a wash. So you can use reusable or disposable, but again, on the reusable, it needs to be part of the terminal clean of a room when the patient's discharged. Those cords need to be part of that cleaning process with whatever appropriate. And I gotta tell you, if you ever get to APEC, the American Professional Association of Infection Preventionists, and you get into their exhibit, it's pretty cool. But they now have cleaning substances that clean across the board all the bugs, including C. diff, so that there's no mistake that, oh, I forgot to clean this room with the appropriate material. So it cross covers. So I found that makes it a little easier for us to make sure we're doing the right thing across the board. So remember, guys, even if you're on the right track, you're likely going to get run over if we just sit there. So part of our job with this is partnering with our environmental people. Make them feel like they are a part of our team, because they are. And get them engaged, get them to understand and be a part of those infection numbers, and be a part of, when you succeed, them being part of that success in the journey. All right, now we're gonna talk about one of my favorite topics, patient decolonization. And this now encompasses both skin and nasal. So we're gonna take a journey. And the first question I'm gonna ask, again, old-fashioned polling, based on the current evidence, what type of daily bathing should be performed with critically ill patients? Is it a soap and water bath? Is it a CHG bathing? Is it packaged bath cloths, or packaged bath cloths activated by water? CHG bathing. Did everybody get that? That is category 1A evidence. Most antibiotics in the market don't have as much evidence as we do with the way we should be bathing. So if anybody harps on that, you just come back and say, oh, category 1A evidence. We need to be doing that. So why is this so important? A while ago, I believe it was 2008 when this study was published, it was a definitive soap and tap water bathing was an independent predictor of a bloodstream infection. So by the way, if anybody is secretly still closing the curtain and making sudsies because they really feel that need for clean, it's harmful, and I'm going to use that word very specifically. With the amount of science we have, it is harmful. So let's talk about the process of why that exists. So let's start with the basin. Anybody still got those pink suckers around? Yeah. So by the way, if they are still around, somebody will use them to bathe with soap and tap water, because we've been bathing that way since Florence Nightingale in the Crimean War. It's a hard habit to break. So they need to go bye-bye. How do you make them go bye-bye? You bring in other things that will help support what people use the basin for. So we'll talk about that in a second. So this was a study, large multi-center study. They had infection preventionists walk in, swab, clean basins, 15 in an ICU, 88 hospitals in the United States and Canada, 62% contaminated basins. Every facility had a contaminated basin. 45% contaminated with gram-negative bacilli. By the way, guys, those are caudy bugs. And they're going to also start looking at UTI, so it's not just going to be about having a catheter in. It's going to be about overall infection. So we got to pay attention. 35% VRE. I don't want to be bathing somebody with VRE. And MRSA was the lowest, which surprised me, but it's also the one we've been working on the longest. So where are these bugs coming from? Well, they're coming from the patient's skin. Remember we talked about the patient being one of the sources? They're also coming from the fact that we use that basin for everything. It is a puke bucket. It is a code brown cleaner. It is a product holder. It literally does all of those things. But the biggest culprit is the bacterial biofilm in the pipes. And you're not going to get rid of it. Hot water doesn't get rid of it. That stuff is strong. The matrix are strong. So your water is fine coming in from your city. It's when it starts the bends coming up to the unit environment. We also know sink drains are a problem because the bacteria comes and goes, hello, and spits out on the counter. So now I've got the bacteria on the counter. So they're building sinks with the drain offset from the faucet because of that science. Amazing how all this evidence sort of hangs around, right? And the thing is bacterial biofilm, it really loves inanimate objects. It's the thing that lines your Foley inside and out. It's the thing that lines your endotracheal tube inside and out, your central line inside and out. It loves pipes. And also, how many have had lunch today? Yeah? Hopefully you didn't have a toothbrush and you went and brushed your teeth, because I want you to have this little experiment. Run your tongue over the top of your teeth. You feel that? That's biofilm. It likes your teeth too. That's why the whole brushing the teeth thing is important in reducing microorganisms. So basically, I got started on this journey, guys, in 1993 when I was on a committee for enteral nutrition at my hospital. And there was a line item. Anybody old enough to remember those big yellow infection control books? The Bibles? They were called the Bibles back then. And there was a line item in there, don't give immunocompromised patients tap water. And I went, okay, why? I went and asked her why, and she goes, we got Pseudomonas in our pipes. And I'm like, okay, I really want to be bathing my MICU patients in Pseudomonas. So there was a nurse inventor that came out with a product called Bath in the Bag. Anybody remember that? So it really improved the efficiency of bathing, which was a big ticket item for my staff, because all I ever heard was, you're supposed to do the bath. No, you do the bath. How come you didn't do the bath? Anybody? Yeah, back and forth. So I wanted to improve the efficiency and the effectiveness, which means it was pH balanced, it was no rinsed, but it required tap water to activate it. So I didn't go with it. And then a bath product walked into my office, literally, in 1995. I grabbed it out of the rep's hand. I ripped the lid open. I went, eat with the cloth to see if it withstood good washing. And then I went like this and squeezed it to see if it would make suds. Because the likelihood that I was going to get all of these humans to change their practice if this thing didn't make suds was about 0 to none. But literally started a 5-unit pilot and brought that in 1996. And we reduced the burden in our environment significantly as a result of that journey. This was before CHG was on anybody's radar. It was getting rid of that. And understanding all water except sterile water and filtered water are contaminated with microbes. So if your patients are drinking water, it needs to come from the filter. And by the way, we also need to dog facilities to make sure that filter is changed every 3 months. Hello, right? How many? Yeah, that's crazy. You know what I do? I make them put a sticker so that I know that sticker is there, and if the date is expired, I'm on the horn and bugging them. Yeah. That's how I did it. It's really immunocompromised patients when they ingest water or the water is on broken skin or you have lines and things like that, that the water really becomes a risk. Transmission of pathogens. How many of you do nebulized or have your respiratory therapist do nebulized treatments? All right, anybody know how that's supposed to be taken care of after it's done? Cleaned with sterile water and laid on a paper towel to dry. What's the likelihood of that happening? Exactly. And by the way, that's why meter-dosed inhalers came in, to reduce that aerosolization of bugs, because that's literally what was happening. They were rinsing it with tap water. They weren't allowing it to dry, and it often went back into the plastic bag that hung by the ventilator. Yeah, exactly. So those are opportunities that you can do it. So there are now a number of research articles coming out of ICU waterless care. So your NG, don't use tap water. Use distilled or sterile water. Tube feeding bag rinse, sterile or distilled water. No tap water on any of that stuff, guys. Really take a look at your practice of trying to eliminate tap water as much as possible as a part of it. This was a 29 evidence-based systematic review of the literature showing tap water is a major culprit for waterborne pathogen outbreaks in our hospitals. And this study's been repeated over and over again. So the data's out there. So where did CHG come in? Well, in the mid-2000s, there was a Concurrent collaboration review that came out that said the 4% CHG in a shower for pre-op surgical prep and a regular shower, there was no difference in infection rates. And people were like, oh my heavens, why? And then they started investigating, and two things. CHG binds to cotton. Everybody's got cotton washcloths at homes, unless they got the spongies. And the second is that CHG needs to stay on the body as a part of it, and you're taking the shower and you're rinsing it off. So what happened is a development of an impregnated CHG cloth for pre-op surgical prep. Then there was a doc in Chicago that said, I've got a big VRE bug fest in my 2 MICUs. So he had 2 matching 11-bed medical intensive care units. And he did, at that point, was the largest BASS study, almost 1,800 patients. Period 1 was soap and water bathing, the pink basin and the tap water and that adventure. Period 2 was the CHG basinless impregnated cloth, and period 3 was a non-medicated basinless cloth. So a bath cloth, similar to the bath cloth I brought in 1996. What did they find? Top line, soap and water bathing, no change. You did see a drop in bacterial load and colonization of VRE with non-medicated bathing cloth, but it wasn't statistically significant. But you looked at the CHG and it just dropped it right out. It went from 26 new colonizations of VRE down to 9 per 1,000 patient days. That is a huge drop in load. The other thing that happened is these guys got a signal that when the CHG was going on and the non-medicated cloth, that CLABSIs were reduced. So that led to that large study that showed tap water bathing as an independent predictor of it. Now, what they also saw is when you drop the load on the human, you drop the load on these puppies, and you also drop the load in the environment. So it was an across-the-board benefit by bathing somebody with CHG as a part of it. Then we had a whole host of studies that came out looking specifically at CLABSI. The top of this forest plot, this is the confidence interval line. Everything on here favors the soap and water bathing. Everything on here favors the CHG. The top is pouring CHG in the bucket and washing that way. The bottom is with the impregnated cloth. All of these are before and after studies, so a much lower level of research. So now I want to get into the higher level of research, and this is when it started to move towards category 1A science. This was a CLIMO study looking at close to 8,000 patients, and they did something called a clustered randomized trial. Because guys, you can't do a blinded randomized trial when you're bathing somebody. It's a little hard. So what they did is picked hospitals, and they matched the hospitals, and so it's the next best thing that you can do based on the intervention. And what they decided is we weren't even going to assess tap and water anymore because we know that's not effective. So we compared it against non-medicated and CHG cloth. And what did they find? 23% reduction in MDROs, 28% reduction in primary bloodstream infection, 50% of that was gram-positive, which makes sense because that's on the skin, right? And this is where our oncology unit started to pick up the practice because there was a 90% reduction in fungal infection, CLAPSIs. So, and they had never, that population had never seen that kind of reduction. So they, as well as the ICU, started to adopt it. And then the big MRSA study came out. So this was done by HCA. They had, I believe it was 160 intensive care units in 16 states. And they did 3 protocols. The first one was what we normally do, or what we used to do, is swab the nose on admission to the ICU, plate it, and isolate them, and see what happens. The second protocol was let's swab the nose, let's plate it, let's isolate them, but let's bathe them with CHG through the entire ICU, and let's put mupirocin in the nose for 5 days, twice a day. The third group was no swab, no plate, no isolate, everybody gets mupirocin, everybody gets the CHG bathing, and it was that group that showed a 37% reduction in MRSA infections, not colonization, but infections, and a 44% reduction in CLAPSIs from all pathogens. This is what moved it to 1A. They bathed over 75,000 patients with CHG. So the safety, less than 1% skin-related issues. So when you look at the science, just like if you're looking at an antibiotic, right? You look at the science that was done on that antibiotic unless it went generic. We have to do the same for our medical surgical products. Because what I'm seeing around the country now is evidence-based practices with non-evidence-based products. It smells like it looks like it, so therefore it must be the same. Not the case. We have to pay attention to that as part of our journey. Then the same group, HCA group, said, okay, what about our med-surg buddies? Let's do the same thing. It was either a shower, the non-medicated cloth, or the CHG. And they also did the mupirocin. What did the data show? The data basically showed is just as a global grouping, this didn't make sense. It didn't show any improvement in MRSA or VRE, colonization or infection. But if you had a device, you saw the reduction. So what the science is telling us, ICU, everybody gets it. Med-surg, if you got a device, you get it. Oncology, you should get it. Those are the ones that should have CHG. The others should have a non-medicated cloth bath as a part of that journey. So, does how we bathe with CHG make a difference? This was a blinded, they could blind this one, prospective randomized, looking at the 3 ways CHG is delivered: by the impregnated cloth, by pouring CHG on a non-cotton cloth, or putting it in the water and washing that way. And you can see, this is the impregnated cloth. When the bath is first done, you can see a high level of concentration of CHG, and you even see it at 6 hours. You look at the other 2 methods, hardly much penetration on the skin. So again, We need to be doing activities that make the difference and looking at the science as a part of that. Now, what about nasal? Mupirocin should be a part of this journey, but there's concern about the resistance piece associated with it because there are studies out. Well, HCA did a study because they were already CHG bathing everybody, so they had half their group do betadine, the iodophor one, and the other was mupirocin. And I got to tell you, mupirocin showed better efficacy. Overall, 18% reduction in regular staph and about 14% in MRSA when they compared the two methods of nasal decolonization. How many of you are doing nasal decolonization? Awesome, because it is part of the protocol of doing full patient decolonization if we're sticking to the science. So, what are you going to do about those basins? Let's talk for a second. All right. So how do you address the puke bucket? Because the little kidney-shaped thing they call an emesis basin, I'm sorry, it is not an emesis basin, it's a spittoon. I was a pulmonary medical ICU nurse, so literally, how many of your ERs have the accordion? How many have brought them up throughout the entire hospital? That's what should be used as it, and it needs to be placed at point of care. All right? What about patient belongings? You can use the patient belonging bag. Sometimes that's hard with all the products, the wound care products. Wire baskets. We brought wire baskets in. They can be cleaned by housekeeping and a terminal clean. And you don't throw away plastic in a landfill. Now, there are also plastic buckets that have holes in the bottom of them. So you can't put water in them. But the holes aren't big enough that the products fall through. So you got to find strategies. Now, I know nurses use the basin for foot soaks. Anybody got shampoo caps? Heat them up, put them on each foot. The patient's going to think they went to a spa. Very effective, and don't be taking them home and using them yourself. Not a good thing, because they won't be around anymore. So the only place in the facility that my friend did this and actually published on how to get rid of the basin, or presented on it, the only place was lab for a 24-hour urine. That was the only place in the hospital that had the basin. And by the way, they creep back. Once you get rid of them, they creep back, so you gotta be on alert. But that's the only way to change that behavior, is get rid of the offending object as a part of it. Okay, let's talk about contact precautions. How are we doing on time? Oh, perfect, we're aligning. For MRSA colonization and MRSA infection, why is there this focus? Because, geez, we've got a ton of bugs in these environments of MRSA and VRE. So how many have about 50% of your unit in isolation at any given time? Yeah, exactly. And I know it was way worse in COVID, but in terms of routine practice, here's some data about isolation. Slower time for the ER to get an inpatient bed, to find an isolation bed. Slower to discharge to an extended care facility. You're laughing there, yeah, you can't find a bed. Delays in diagnostic imaging, because we've got to set everything up for that. They're visited 20% less by us, because we got to garb up as a part of it, and there is greater patient dissatisfaction, depression, and anxiety. So the question is, can we do something about this? Well, the problem is most of the studies have been good studies, but single center. So the CDC is not willing to go there yet and make the recommendation. But what's the data showing? This was an 865-bed safety net academic center. They did a quasi-experimental before and after 30 months. They discontinued contact precautions for MRSA, VRE, colonized infected patients. And what they did is they ramped up their hand hygiene. They instituted chlorhexidine bathing, except for infants. And they also went bare below the elbows. So this stuff wasn't touching things as a part of it. And what did they find? They had no difference in their MRSA and VRE rates before or after discontinuation of the contact precautions. Interesting, right? And they had lower CLABSI rates after they discontinued the precautions. Another study, this was done over a 4-year period, interrupted time series. They started the change in 2011. They had been moving to daily CHG bathing in the ICU. They put in the BSI checklist, bare below the elbows, hand hygiene, daily urinary catheter review, and disinfecting caps for IVs. So you can see how they had all of that as a part of it. And then they discontinued. So before discontinuation, their MRSA device-associated infection per 1,000 patient days was 5.19. It went down to 2.88. So they actually had an improvement by removing the contact precautions. VRE, same concept, all statistically significant reduction. And they had all pathogen device-associated infection reduction that was statistically significant. However, the CDC is not going to change their practice because these are single center studies. So what I'm saying, back to the CDC, get a big study out there. We study other stuff. We need to be able to study this as well as a big center study. Now, contact precautions are still indicated for CRE, all the funky ones coming up, CRPA and CRAB. I know, isn't it bad to call something CRAB? I know. Is there a better way to evaluate donning and doffing? Now, during COVID, how many of you were inspected for your donning and doffing process? When was the last time that happened? Yes, right before, probably in the last 5 months of COVID. And then it just went, do you think we fell off a little? Oh, every likelihood. So there's got to be better ways of doing this. I think it needs to be part of our routine yearly competencies because it is a critical behavior as a part of it, and then provide feedback in it. Now, I have a colleague of mine who actually created this. I love nurse inventions. If any of you know, I created a prone device a long time ago. So I'm into nurse entrepreneurs when they look at different things out there in the world. And what she did is tried to address the doffing process. You know how your wastebasket fills with all of those gowns? She just created a little pocket inside the gown. You take the gown off, it goes right into the pocket, and then it goes into the trash can, and it's about this big. Simple but effective. And she's still on the process of trying to make this happen, big scale, as a part of it. And then practicing device related. One of the things, and I'm going to see if I have enough, yes. One of the big things, if you have not worked on it, is urine cultured stewardship. How many have worked on that? How many have criteria for when in their EHR? Yay, so you can follow that. Hopefully you don't put an other there because they always want to check the other. How many have gotten rid of reflux cultures? So reflux cultures are basically, I have enough WBCs, I get a UA, I have enough WBCs or nitrates, and it automatically flags to a culture. Problem with that is it's not connected to signs and symptoms. So therefore, there's every likelihood you're treating an asymptomatic bacteria. And antibiotic stewardship says that 23 to 50% of our inappropriate antibiotics focus around UTI and CAUTI, because of that asymptomatic bacteria piece. So there's two things to do. One, get rid of it completely, but if you can't convince people, you will convince them after lab is required to call the treating physician every time they want to flip it over to a culture to ask for the signs and symptoms. By the way, that'll last for 2 months, and then they'll just say, let's get rid of it. As a part of it. There's, we know how ways to skin the cat, right? Make it happen. So CAUTI, CLABSI, and vent pneumonia and non-vent pneumonia. How many are aware that CMS and the CDC are starting to move to all-cause bacteremias? It's going to go that way, guys. So putting a midline in to take out, to not have a central line, it's going to be all your peripherals. It's going to be everything combined. And there is also a push for non-catheter associated UTI. So the use of the externals, there's going to need to be assessment of what kind of UTIs we're addressing with various strategies we're using in the environment. And very soon, I hope, non-ventilator hospital-acquired pneumonia. Because Michael Klompus, who wrote was lead author on the VAP revisions, his group developed an electronic extraction that is accurate for non-vent pneumonia. So you can do it real time and actually get your numbers, and they're accurate so that you can start putting in quality improvement projects. And the number one strategy is effective oral hygiene, nursing, save people's lives as a part of that journey. And as I said, antibiotic stewardship, it's absolutely core to this journey. 30 to 50% of antibiotics prescribed are unnecessary, and most of that is UTIs. 2.8 million antibiotic resistant infections in the United States. Stewardship programs, one of the benefits of the CDC implementing core elements for antibiotic stewardship. Hospitals, when they started this in 2014, only 41% of the hospitals had it. In 2018, 85% of the hospitals had it. So guess what they did? They now have core elements for sepsis, thinking they're going to get help in the same way and have that uptake of developing strategies, core strategy programs to make the right thing happen for our patients as a part of it. So, horizontal approach, guys, it does work. It really does work. When you implement strong hand hygiene, you're going to add the stethoscope hygiene to that, the chlorhexidine, the oral care, the CLAPSI, the CAUTI bundle. And what's so exciting is this is the power of our nursing care, guys. It really is the power of our nursing care. These guys went from the time they started with a fairly high rate of MRSA, they had a 21% reduction every year, and by 2008, they were at 0. By adding all of these components to their journey. So it really does work. So basically, I'm going to leave you with this quote: when would now be a good time to do this? It's not enough for us to know what to just do it. We've got to know what to do. And if we know what to do, then we can do our best, right? So I'm going to bug out right now.